Yes.
Yeah.
Yes, sir.
All right, let's start with seizures, and let's differentiate between seizures and epilepsy. So seizures is an uncontrolled sudden excessive discharge of electrical activity. Depending on the type that you have, will be the resulting signs and symptoms or manifestations during the seizure. Like I said earlier in lab, we will only discuss the tonic-clonic type, which is the most common type of seizure. So we won't do the absent seizures, the or any other types of seizures. Now, you can have more than one seizure in your lifetime as long as there is a cause to the seizure. Say, for instance, you have a high fever, for instance, like myself, I've had, of course, I don't know personally because my parents told me. My mom specifically told me how many seizures I've had as a baby. I frequently had high fevers. They really don't know why, but each time I would have a seizure, and she'd take me to the doctor, not to the hospital. And of course, the seizures over by the time she gets to the doctor, and then the doctor just tells and then treats me for the infection. But I don't have epilepsy. Epilepsy is different. So, as defined here, this is a chronic disorder characterized by two seizures unprovoked, or there is no immediately identifiable cause. Right, so that is now epilepsy. Now, um, so therefore, even if you have multiple seizures, as long as there is an unidentifiable cause or there was a precipitating event that triggered the seizure, then that is not epilepsy. Epilepsy is usually um, a seizure not attributable to any cause, meaning after examination, the doctor runs tests, takes a scan of your brain, does some metabolic testing, for instance, lab work. They can't explain why you have seizures, then you are diagnosed with epilepsy. Any question about the difference between a seizure and an epilepsy? Any question? Okay, that's clear, right? All right. So this is what I mean. Table 36-4.4. We were only talking about the or testing the tonic-clonic seizure. So in tonic-clonic, this is the signs and symptoms. So the patient usually has loss of consciousness. In fact, I've never seen anyone or taken care of a patient with a seizure, well, a tonic-clonic seizure was still awake. Okay, all of them have a loss of consciousness. It varies though as far as how long, because the activity is very violent. There are two phases here. There's a tonic phase wherein all the muscles of the patient from head to toe goes rigid. Okay, so if you lift the leg, for instance, it stays like that. If you raise the arm, it stays raised. So the muscles become rigid, and then it will be followed after a few seconds by the clonic phase. So there's now rhythmic jerking of all the extremities. So the patient is shaking uncontrollably while some, if not all, of the muscles are still rigid. So you can just imagine how much energy this patient is expending during the seizure. Plus, the most serious part here is the brain, because really what triggered the seizure, the rigidity and the jerking, is because of increased intracranial pressure. So you can just imagine how much energy or how much electrical activity is also occurring inside the patient's brain. They can get incontinent. In fact, most of them do. There is a shallow breathing because, again, have you ever tried shaking and being rigid and then breathing normally? Can you simulate that? I can't see you guys, but try doing that. Try making your muscles rigid and then shake and then see if you can breathe normally. I just tried it. It's impossible. It lasts about 1 to 2 minutes. The post-ictal phase, meaning after the seizure phase, can last several hours. If not, some patients may never regain consciousness until overnight. So let's say this occurs at night, right? They don't wake up or regain consciousness until the morning. Okay, so it can last up to 8 hours or even longer. Most of them have no recollection of the event. They, I'd say over 99% are unaware that they had a seizure. They only find out that they have a seizure if, let's say, these people have epilepsy, meaning they're used to having seizures, especially if, let's say, they go off their medications and that will trigger seizures. They find out when they regain consciousness. Of course, this patient is aware that he has epilepsy, for instance, and then they're aware, oh, I just had a seizure, because they can tell they have these injuries on them. Let's say they bump their head, or they have bruises on parts of their body, and they can't remember how they got it, so they conclude, oh, I must have had a seizure. All right. The danger here, if they're alone, because nobody can put them on their side, because they could potentially aspirate during the seizures, because again, they have no control, they have no recollection, they're not aware of the seizure. Although there is a pre-tonic phase called an aura. Some patients may have an aura phase. The aura can vary from patient to patient. Some patients have an aura of, let's say, they lose vision in one or both eyes, for instance. Some will smell something funny, or somebody will have a different taste in their mouth, or they'll have some. I know Stella, girl I went to school with in elementary school. She's always had seizures. Like in throughout the school year, she would have 2 or 3 of them. And the problem was we get used to it, and then we learn to ignore her. Her auras were she would make these. Have you ever met people with Tourette's, wherein they make these sounds like they have no control over them, like oh, so that's what Stella was making. So she would go, oh! And then the sounds she makes would get more frequent just before she gets the seizure. So she'd go, oh! And then a few minutes later it'll become more frequent, oh, oh, oh! And then we know what's going to happen next. The the worst part of it was our teacher would do nothing. Of course, the first time it happened, she probably freaked out, but then because it got, she learned that, oh, this is completely normal. But I mean, she would just literally continue on with the lesson, and then she would, because her chair, Stella's chair, would now topple over. Now she's on the floor, and then none of us knew what to do. We were never told what to do. Unlike now, of course, I know now that, you put the person on the floor so that they don't have to fall, and put them on their side, not to restrain the movement. But this one, we just left the poor thing alone. So she would, topple over, and then she's still partially on the seat, so of course she'd have these several bruises on her legs, and sometimes, she'd get these cuts because she's still on the chair. Anyway, so that was a unpleasant memory. I lost track of Stella. I don't know what happened to her. She was a nice chick afterward. I mean, otherwise, she was nice to talk to. She was a nice person. She disappeared. I never saw her graduate in the same school. I don't know what happened to her. These are the other causes of seizures. So you have fever, and then of course trauma, surgery, tumors, or even a stroke. Especially hemorrhagic stroke, because that one causes increased ICP. Manifestations again will vary per stroke. I mean per seizure, per type of seizure. Um, so the pre-ictal phase or before the seizure, again, there are auras. So these are some of the um, auras that have been reported. And post-ictal phase, like I already mentioned earlier, this would vary again. The period would vary from person to person. Some people may regain consciousness sooner, but some people take longer. Again, it's a very violent episode. It's very exhausting, so you can understand why they would continue on to sleep, because that was a very tiring episode they just experienced. Even if it lasted only 1 to 2 minutes, it's still very exhausting. These are some of the causes of seizures again, aside from the ones listed up here. Right, where was it? Oh, up here. So they have it on the table. All right, so this would be a very nice select all apply question. The reason why this is tested is, who will you monitor for seizures? So let's say the question will go like that. Which of the following patients will the nurse monitor for possible seizures? Select all that apply. Got it? So this would be, it could also fall under prevention, to as far as maintaining safety. So you monitor these patients for possible seizures, including in city hospitals. Most of our patients that have seizure tendencies are those admitted for substance abuse withdrawal. So alcohol withdrawal, remember how long before people can have alcohol withdrawal? How long after the last drink? Oh, you don't have psych yet, right?
Nope, next semester.
Okay, never mind. The seizure is managed mainly with medication. There's nothing else. Of course, during the episode, your priority is safety. Maintaining airway, keeping the patient safe. Um, and then if you have an IV site, that's good. You can, especially if we're dealing with a medical emergency, which is a status epilepticus, is if this patient has a seizure lasting more than 5 minutes, or if they have one frequently 30 minutes apart. So obviously they have not recovered from the last seizure they have, and then they get another one, then that's life-threatening already, meaning the brain has not recovered yet from the last seizure, and then if they get another one, then that will cause brain damage. As far as the seizure lasting more than 5 minutes, of course, you already know that the breathing is affected, right? It's you get shallow breathing, so of course, the longer the seizure lasts, what will happen to your to oxygen delivery to your brain?
It would decrease.
All right. So therefore, is it good or bad to have non-stop seizure or a very long seizure?
Bad.
Very bad. All right, let's go to the medications now. As far as arriving at a medication choice, as well as the dosing and frequency, this is all done by trial and error. So there's no one shot, meaning there's no neurologist out there that can pinpoint, oh, for your seizure, I'm going to give you Dilantin, 300 milligrams, 3 times a day. Okay, see you in 1 year, or see you, in 6 months. No, the medication will be at all trial and error, because we don't know which one the patient will respond to and at what dose. Plus, the dosing will also be a concern depending on the medication, because look at the side effects. Right, so some of them cause hepatitis. So therefore, of course, not every medication will be applicable to each patient. Say the patient already is an alcoholic, or already has liver damage. So that will narrow our choices, right? So the doctor here again has, and the doctor and the patient actually will have a huge task of arriving at a appropriate medication. Unfortunately, all these medications, 10 of them are used in clinical. I can't say that only one of this versus the other. Okay, all of them are used. The frequently used one though is phenytoin. So among all of these, it's phenytoin or the lantan that is most frequently used. And you do have a level here. So this is your normal, or let's say therapeutic phenytoin level. It should be 10 to 20 micrograms per milliliter. The problem with phenytoin is, if you look in the drug book, not here, if you look into the drug book, this is probably the only medication with so many drug interactions. I think it covered, if not one page, probably a page and a half list of medication that it interacts with. So to be safe, whenever I give phenytoin, I never give it with together with any other medication. It has to be given separately on its own, because I already assume, I mean, it's bound to interact with any other medication. Okay, so I don't give it together with other drugs. These are the common side effects. It causes gingival hyperplasia. It's very known to do that. So mouth care is very important for these patients. Do you know what nystagmus is?
No.
That's yeah, controllable eye movements. Um, I won't discuss each one. This is your job to read. It's basically memorization. I don't know how you're going to help yourself remember these. All I can say is I'm so glad I'm already done with my NCLEX. These are, again, all 10 are used in clinical. You'll see patients on Tegretol, on Clonopin, although you've given gabapentin, right? Yes? Or you've come across this, especially diabetics?
Yes.
Yeah, okay. But you know, it's not used for seizures, right? In the diabetic patient.
No. So it's a
Yeah, what's the
neuropathy.
use?
I think it's for
What's that?
neuropathy symptoms.
Okay, very good. It's for neuropathy. So that's what we call. And then we discussed this under pain, under the pain chapter. Gabapentin was used for neuropathic pain, right? Like the ones that diabetics have, the neuropathy, as well as any other neuropathic pain, let's say phantom limb pain also, as well as pain in shingles. So those are managed with anti-seizure medications. So you'll see some of these medications, especially the GABA group, used for that type of pain because they work very well. You've seen this in hospital. Levetiracetam is usually used for prophylactic, especially after head injury. So if you see these patients put on this, although they've never had a seizure in their life, this is usually the medication they use for to prevent the seizure. Look at the side effects. They have the most. They have the if you look at all the medications listed here, this probably has the most mild symptoms. Okay, they just have fatigue, loss of appetite, a runny nose, and a little bit of gait imbalance, but that's pretty much it. Okay, that's why it's very popular in traumatic brain injury patients, and some patients with epilepsy are also on levetiracetam. But the most effective, however, is phenytoin. That's why it's also the most commonly used. Phenobarb, the benefit of this is the sedation. So if you have elderly patients who have epilepsy, they put this because especially if the patient also has dementia and all that. So the benefit there, of course, this is, I'm talking really bad here. I'm talking very selfishly. I'm just being honest. Okay, so the sedation there is actually good because the patient goes to sleep while on phenobarbital. So it's like a sleeping pill. In my mind, when I administer it at night, good, patient has phenobarbital, so they'll sleep, and you'll have a very nice shift. You've also seen pregabalin, so it's still another GABA drug like gabapentin. This one used for other pain as well, for fibromyalgia, chronic type of pain. That's used. That's where Lyrica is used. Any question on drug therapy? So
What
that's
the
10
criteria
plus.
look like in that about this box?
Well, the usual. I give you the drug. The patient is taking this. What would you monitor in the patient? Could be multiple choice. Could be select all that apply. Again, all of them are used, so I can't pick and choose which one to test because they're all used in clinical. Let's go to complication and management. So as I mentioned, status epilepticus is something you don't want to see because this is already a medical emergency. If the patient has a seizure lasting more than 5 minutes, or the patient has um, seizures within a 30-minute period, meaning the patient obviously has, like I said, has had no chance to recover, particularly their brain was not able to recover, then that would add insult to the previous injury. If untreated, this can result in these: respiratory failure, brain damage, and death. The most common cause of status epilepticus are the following: head injury, hydrocephalus, acute drug or alcohol withdrawal, metabolic disturbances, especially in, remember in ESKD, end-stage kidney disease. If let's say the patient misses 2 or more dialysis sessions and their creatinine is, let's say, 27. Have you ever seen a creatinine of 27? Usually dialysis patients get anywhere between 7 and 12 creatinine. I've seen someone with a 27. Of course, this is after the patient died. The patient had no idea he was already in kidney failure. He had a seizure. That was the only. Of course, he didn't feel well. He was driving. He went home, um, then had a seizure at home. Taken to the hospital. Did lab work. I've never seen a patient like with a creatinine of 27. I thought it was BUN, but no, it was his creatinine was 27. So patient had a seizure, never recovered. And also abrupt withdrawal of anticonvulsant medications, meaning the patient, let's say, was hospitalized, was NPO, and nobody bothered to check that they were on seizure medications, and was um, overlooked, and then next thing you know, a patient has a status epilepticus. So this is one of the exceptions. Have you ever talked about pre-op in a previous semester when a patient is NPO? what did you learn about being NPO? Is that absolute or are there exceptions there?
Exceptions, nothing by now.
Yep, NPO. This is one of the exceptions. However, you still need an order though. So if a patient is on steroids, anti-seizure medications, beta blockers, hormones, when I say hormones, I'm talking about hormone replacement besides steroids. So let's say for thyroid hormones, for instance, okay, or mineralocorticoids, right? So something that patient takes every day. Those there will be exceptions there, but you still need to notify the physician. But of course, the doctor won't know unless you tell them. So nurses have to be aware about which medications must never be stopped. So all you do if you have a patient with an NPO order, of course, you call the doctor and tell them, doctor, your patient is on metoprolol, patient is on Tegretol, patients on Dilantin. Okay, what do you want me to do? So he'll just simply say, okay, give the drug with small sips of water. All right, but that's your responsibility. Because imagine this patient going to the OR, for instance, and then having a seizure right there on the operating table. So if your patient is known to have epilepsy or the patient has any of these admitting diagnoses like head trauma or metabolic, ESKD, renal failure patients, um, always make sure they have an IV access because you think you can put an IV during a seizure?
No, you're not supposed to really even touch the patient.
Yeah, I mean, good luck trying to put in an IV. It's impossible. So that way, if this patient goes into a seizure or worse, goes into status epilepticus, you already have an IV. Now, to stop the seizure, you have choices here. You can give lorazepam, midazolam, or not listed here is you can also give Valium, which is diazepam. So lorazepam, all the PAMs, okay, all benzos. So lorazepam, midazolam, or diazepam are the treatment for status epilepticus. We typically don't give Versed. Versed is reserved for conscious sedation. When you're doing a procedure, let's say a dental procedure, for instance, or a colonoscopy, something short term. Or let's say remember the video you saw with the peg tube placement? Yeah, we also use midazolam there. So if you need short-term sedation, that's where Versed is used. But for status epilepticus, it's usually this, lorazepam or diazepam, Valium or Ativan. That is only to stop the seizure. Now, to prevent further seizures, the patient will have to get um, other anti-epileptic medication. So starting with phenytoin. So this will be given IV in a drip. So the phenytoin will be running continuously. Levetiracetam is PO. So we will use that once the patient is already awake. And if they don't respond to any of those we just mentioned, here they are refractory to all those interventions, then the patient will have to be sedated big time. So we'll put them in a propofol drip, which is, of course, this one is a heavy sedative, as well as pentobarbital. So pentobarbital is to put them in a coma. Propofol, you've heard of it. This was very famous with Michael Jackson. You remember uh, the um, um, the documentaries on Michael Jackson with who was that doctor that went to jail? Dr. Murphy? Was that the guy's name? Anyway, so Michael Jackson, in order to sleep, was receiving propofol already, but at least according to the documentary. Surgical management, I have no questions because I know several patients who, even rich people who have epilepsy. I don't think this really works. So I have no questions on surgery. We will only stick with medical management. And here's your nursing. The let's see with our interventions. Okay, so during a seizure, what should you have available at the bedside? So suction and oxygen equipment should be there. If the seizure is witnessed, then do these. So just maintain safety, turn them to the side. So that's the aspiration precaution. So you do not restrain the patient. Do we put anything in their mouth? That way we keep them from biting their tongue.
No.
You know, padded tongue blades, can we do that?
No.
No.
No. Okay, so don't attempt to put anything in their mouth. This should have been in place already because can you still put it again during a seizure? No more, impossible. Here documentation. So once the seizure activity, at least one of you, whoever that is, one of you should already keep track of what time did the seizure start. Because next thing you know, it's already past 2 minutes and it's already 5 minutes. So we need to know whether or not we need to stop the seizure using medication. If it's, or what I'm trying to say is, if it's already status epilepticus. All right. And teaching for the patient, under no circumstance should they stop the medication. If there's any reason wherein they cannot take the drug, they're supposed to call their doctor. That way we can give an alternate form of the medication, but they should never stop taking them. What's the danger again of stopping anti-seizure medications abruptly?
You can return.
I know, but what's the more medical emergency that could result if you stop taking the medication? We just finished talking about it. What was it? Hello? Read this for me, Miss Jesslyn. Okay, I guess everybody checked out. All right, so
It says abrupt withdrawal of anticonvulsion medications.
okay. All right. That's it for seizures. Any questions? All right, let's go to the eye and ear problems now. Let's start with page 958, chapter 46. The most common eye disorder is a cataract, although caused most commonly with age, but there are non-age related cataracts as well. The
I don't see the screen.
But I gave you the page number.
Oh.
958. All right, so again, age is the #1 risk factor for cataracts. So by age 80, look at this, more than half of Americans will have cataracts. Non-age related cataracts are caused by the following. So we have exposure to UV light. We already have advanced age, family history, race and ethnicity. So African Americans are at risk for cataracts, as well as Hispanic Americans. Diabetics. My mom, I remember, had bad cataracts, so she had poor vision until she died because she could never get surgery because her sugars were never under control and one of the requirements. Obesity, hypertension, exposure to some chemicals at work or in the environment also can lead to the eye that is deteriorating. It's the lens. So the lens becomes cloudy. Supposed here, and of course, is the protection besides the cornea layer. So this is our protection for the delicate eyes. So if you have debris there, it will just come in contact with the lens and not go straight into the eye. So it's supposed to be clear, like a window, a clear window. But just like a window, which a window gets old, blurred, and this is what happens in a cataract. So nothing is wrong with your retina, nothing's wrong with your nerves. This is physically there's an opacity to the lens. There's no other treatment. There's no eye ointments or eye drops that can um, um, manage it except just surgery. So how do you know he got cataracts? So the patient may not notice it unless they literally look at their eyeball in front of a mirror every day. So the symptoms will be the patient's vision will be clouded, blurred, dim. They'll have poor vision in general. So these are all your symptoms. Now the patient usually gets cataract only in one eye, but you can have it in both, but they're usually one eye is worse than the other. So if they say the patient has cataract bilaterally, they'll do surgery on one eye at a time. Of course, for obvious reasons, you don't want to keep the patient blind because they will have to wear an eye patch post-op. So therefore, it's not advisable. It's not really a good idea to do surgery on both at the same time. So they'll usually do the worst eye first, and then once full recovery has been reached, then we'll do the other eye next. As I mentioned, there's only one. There's no eye drops here, so no need to memorize anything, at least for cataracts. So surgery is your only treatment. It is a cure though. Once you remove the lens and then replace it with an artificial implant, then it's cured. For some people who do not, for some reason, there's a contraindication as to putting in a lens implant, then of course we will need to have corrective lenses, for instance, right here. If a patient is unable to have a replacement lens implanted, then once cataract is removed, vision correction is achieved with lenses. The number one complication of eye surgery, I really don't want to show you any videos because I probably could play it and then not watch it. I just can't tolerate watching the video. It's too violent for me. Okay, so if you guys are interested in how it results in retinal detachment, I mean, if you could see the violence that the doctor does during the surgery, I mean, you'll realize why the retina would be detached. Okay, it's very violent. Well, and that's just cataract. Imagine if they have to do other eye procedures like repairing a retinal detachment, for instance, or if they're applying a what's called a scarabuckle, which is we'll talk about those later. They're even more violent. Okay, because what they'll do is move the eye. Of course, you're out for this. You are, of course, not aware, but they'll move your eye using bands and I mean stitches, and then they'll move your eye up and down. Anyway, I can't bear to watch. So I have no question on the procedure itself. So this is nursing, so we're only concerned with pre and post-op. So pre-op, of course, you tell the patient what to expect. And this is just a description of the procedure. So they take out your old lens and then implant a new one. So pre and post-op. Now remember I said there are no ointments or eye drops needed, right, for cataract. However, after surgery, patients will require eye drops, this time not for the cataract but for the procedure, because you had a cataract removal, so you will need antibiotic ointments, eye drops. So that's when you actually need the eye drops, but it's not for the cataract but rather for the procedure. And these are the rationales for the patient's symptoms. Please just read them on your own. The question on this would be probably related to teaching. So let's say the question goes, the patient is asking why they have blurred vision, and this is your answer to, this is your response. So question would be, what would be the nurse's best response? Okay, so that's for table 46, that's 9.9. Eye drops, we'll review the procedure shortly. So again, the eye drops here is not for the cataract, but rather for the procedure. So the patient will be given a mydriatic to dilate the pupils so that they can do, because dilating it, of course, relaxes the blood vessels. They can easily remove the lens. And then there's another eye drop here, cycloplegic, which will paralyze the ciliary muscles so that the eyes also do not move. Post-op, patient will be in what's the purpose of this position? This will also be the same position in brain surgery. Intraocular and intracranial pressure are affected by the exact same factors. So let's say bending down, does that increase intraocular pressure? You know, when you're bending down to pick up something?
Yes.
When you're giving birth to a 6-pound turd?
Yes.
Yes. When you are singing at the top of your lungs, say you're
Yes.
doing a Mariah Carey. Yeah, when you're you're holding your breath there. So any condition that leads to you taking a deep breath and then holding it, so that would also include sexual intercourse. That will also include playing a saxophone or a trumpet. Blowing your nose does the same thing. So any or coughing, for instance. Okay, so any condition wherein you take in a deep breath and hold it. Sneezing would also be included, because that's this. You do the same thing. In order to sneeze, you have to take in a deep breath first, right? Same thing for coughing. That's why choking patients can't cough, because you have to be able to take in a deep breath and hold it before you can do that. Position the patient on the non-operative side or straight flat on their back. Eye patch, this will decrease rapid eye movement. As already mentioned, stool softeners and any other activities that will increase intraocular pressure or intracranial pressure. Like I said, they're the same. This one is on prevention of cataracts. And vision is always a safety issue here. You can't see, then you are in danger of falling, bumping into stuff, or any other injury. Let's say getting run over by a car, falling into the train tracks, who knows. And here's a safety alert on what to do. I mentioned some of them already. So sneezing, coughing, bending over. Oh, I missed vomiting. So vomiting and lifting objects. We did constipation. So what to report after surgery are the following. If they have that severe pain, visual changes, or increase in eye discharge. Now, for the eye discharge, you and I get eye discharge every now and then, correct? Especially early in the morning. Yeah. There's a crusting that forms at the corner of at the or inner canthus, right? So that's expected. For these patients, of course, there's a lot of irritation there, a lot of trauma. So of course there will be increased crusting there. But as long as the crusting is white or yellow, that is fine. But if it's a different color now, or let's say there's increased bleeding, for instance, the eye, by the way, will appear bloodshot. Of course, it will be bloodshot, just like anybody who underwent trauma from surgery, right? There's expected to be, it will appear bloodshot, but that's expected. All right, as long as the patient doesn't have any severe pain, because the vision should be clearer after surgery. However, we don't want them to use that eye yet for obvious reasons. We don't want, because that eye just underwent trauma, so that's why we wear the patch, because we don't want them using the eye for 24 to 48 hours. And after that, then of course we can remove the eye patch, and then the vision should be 100% better. And always in this direction, just like when you wipe your perineum from back to front, right? So this one will be wiping from inner to outer. Here, glasses will be worn, which we discussed, we pointed out already. There was a statement, if the patient can't have a lens implant for some reason, then there has to be protection. The glasses here is not only used to improve vision, but also to protect the eye, because there are no lens. So that would make your eyeball very vulnerable. And that's it for cataracts. Any question? All right, let's proceed straight to the next eye problem. Glaucoma. This can affect not only the elderly, but children. In fact, we had a student three years ago. Yeah, probably 3 years or longer ago. She's had cataract, she said, since she was 6 years old. So you can imagine how thick her glasses are now today, because imagine she's been getting eye drops since 6 years old, because that's a treatment for glaucoma. What I'm trying to say is it's more common than we think. Look at the amount of people affected. So estimate is about 2.2 million people have glaucoma, right? And then that's only the ones that were diagnosed. So how much more the number could be, if we include those that are undiagnosed. So the problem here is an increase in ocular pressure, intraocular pressure. The normal pressure is, I think, 15 to 20. Or is it 15 to 21? I can't remember. It should be mentioned in a little bit. So if the intraocular pressure is greater than 21, of course, imagine your eyeball. So the pressure there should only be within a certain range. If you increase the pressure, it's not like the eyeball will pop out of your eye socket. It will just compress the blood vessels and the nerves behind it. So therefore, if you keep increasing the pressure, of course, that will lead to compression of those fragile vessels and those fragile nerves. We're not only talking about blood supply here, but also nerve function. So once you compress your optic nerve, of course, that's permanently damaged, then no more eye function. Okay, you cannot transmit signals already from your optic nerve to your brain, so therefore you cannot see. You are blind forever. There is no cure for glaucoma currently. We can only prevent it from getting worse, meaning we're trying to preserve your vision. But again, there's no cure. So the reason here is one of two things happen, or both things may happen. So you either have an increased production of your aqueous humor, this is the fluid that keeps your eyeball round, or there's a decrease in the drainage of that aqueous humor. So the structures in the eye is made in such a way wherein there is a constant production of aqueous humor, while there's also a constant drainage and elimination of your aqueous humor. If we have a balance, we have no problem with our vision. Okay, so the eyeball keeps the same shape. We need a constant flow of aqueous humor, because imagine putting the same fluid there for the rest of your life. Of course, that fluid will deteriorate. You'll grow something there. So that means the fluid must be constantly produced and then also constantly drained. Again, as long as that balance is maintained, then we have no problem. Problem starts when one of those occurs. So you have an increase in aqueous humor production, and or the drainage is obstructed. These are your other risk factors. Okay, the one we will be testing are these two. We have primary open angle glaucoma, which is the most common, and then this one, because this is the more serious type, acute closure glaucoma. So these are the two that we will be testing. Again, primary open angle glaucoma, and the emergency, which is of course rare. However, this is emergency because you lose vision faster with acute closure glaucoma. What makes primary open angle glaucoma serious is it has no early warning signs. By the time you have symptoms, it's probably too late already, because at that point you've lost so much of your the damage is so much that it becomes irreversible, and then blindness will follow. In acute closure glaucoma, the difference here is the eye pressure, as stated here. Although rare, the eye pressure rises very quickly. We're talking about a few hours. So the patient's symptoms appear so fast, and so therefore the damage to your optic nerve will also be just as fast. Not testing the secondary glaucoma, although just be aware of the causes. It's from eye injury, inflammation, tumor, cataracts, or even diabetes. But again, we'll focus on primary open angle glaucoma and acute angle closure glaucoma. Okay, since the damage occurs first on the periphery, so unlike a cataract wherein it was in front of you, because the lens is right in front of the eyeball, so therefore the loss of vision is right in front. Okay, the like straight tunnel vision, right in front of you, because you have a clouded lens. This one, it's in the periphery, so the patient will report vision changes like a curtain is being closed in front of their eyes. So like a stage curtain. So stage curtains close from the side going to the center, right? So it'll be like that. So the loss of vision, the gradual loss will be like a curtain is closing. So they'll literally lose peripheral vision, and then over several months and over years, the curtain is slowly closing in front of them. So the patients adapt, they have to turn their head in order to see what's on the left or right sides of their vision, because that's already gone. So it's like, know how horses are? The horses wear this, what do you call that? The ones we ride in Central Park?
Blinders.
Blinders? What is that?
Horses with blinders. Yeah, yeah, they're called
Yeah.
blinders.
Okay, yeah, so it's like that. So like it's like wearing blinders, okay? So that your peripheral vision is impaired now, so you have to literally turn your head in order to see certain so you have blind spots now, okay? And just imagine, instead of years and several months at least of the peripheral vision loss, in acute angle closure glaucoma, this one is all of a sudden. So you'll have severe eye pain, nausea, vomiting, and then this pattern of vision loss. Here's the normal IOP. It's between 10 and 21. So anything higher than that, then that's already glaucoma. For those who wear glasses, when you do your annual exam, your doctor measures your intraocular pressure, right? Who wears glasses here? Or at least those that see a optometrist. Unlike me, I stopped seeing my optometrist for 2 years now. I've just been purchasing reading glasses, which is probably a bad idea. Maybe I should see them back next year. So intraocular pressure measurements are now routine. So if you see a optometrist for whatever reason, they will automatically measure your intraocular pressure. It's covered by insurance. It's not an extra fee because it's again part of preventive care. So it should start as early, the earliest possible. So if you have kids in public school, I'm sure kids are also screened for this, because again, glaucoma can start early. So the only way we can prevent blindness is to maintain eye ointments. Eye drops. Why do I keep saying eye ointments? There are surgeries, but the mainstay of treatment is really eye drops. Here are our medications. So just like the medications for seizures, all of these are used. So I cannot again cut down on any. Plus the patient will most likely be on multiple. I've never seen a glaucoma patient with only one eye drop. Usually they have a minimum of 2 and a maximum of, there is no maximum. I've seen someone with 6 different eye drops. All right, so these are the drug classes. We have prostaglandin type. Prostaglandin is what again? We keep saying prostaglandin inhibition, which is the action of NSAID. So what is prostaglandin? This is your clue here. What is the action of prostaglandin? Prostaglandin, therefore, if it increases outflow, it increases drainage of aqueous humor. So what does it do to the smooth muscles? Does it cause dilation or constriction?
Or
Dilation.
Dilation. Okay, so prostaglandin is a vasodilator. It also affects smooth muscles because blood vessels are smooth muscles. So vasodilators will help increase the drainage of your aqueous humor. Then we have beta blockers. Beta blockers have vasodilating effects also, right? However, they can also cause a decrease in production because it's a beta blocker, so therefore it blocks adrenergic symptoms, right? Adrenergic effects. So it also reduces the production of aqueous humor. And you have alpha antagonists. Plus, the names really sound the same. Look at prostaglandin types. So it's pros, so they end in pros, right? There's a pattern to it. Latanoprost, bimatopros. So those are prostaglandin agonist medications. You have alpha agonists. They end in brimonidine. So in nidine, okay, or onidine, apraclonidine. Although I've never given this one. This one is the more popular brand, Alphagan. Who works in long-term care here? I'm sure you're familiar with these medications. Yeah, your long-term care patients, glaucoma. And
Yeah.
yeah, so these things are given every day, and this falls, I believe, in the night shift. Okay, so if you work night shift, you're the ones giving the eye drops early in the morning, which is challenging because if you have your long-term care residents sleeping in, that means you'll have to wake them up to give the eye drop, and the rule is you can't give them one after the other because the other medication will wash out the other, so you have to wait 5 minutes between eye drops. And if it's 2 drops of the same medication, you're supposed to wait 1 to 2 minutes between drops as well. So it'll take a long time, and this is just one patient. Imagine if you have 6 patients all having glaucoma, all having these um, eye drops. Okay, and then this is again lifelong. Okay, it's not like a week, you use it for a week. This is lifelong medication. So let's change the patient because we always talk about the elderly. What if this patient is a teenager? Is it sexy? Is it popular? Is it cool to be putting on eye drops? Is it macho?
No, it's not cool.
No. So this will be a challenge with your younger population as well. So teenagers with glaucoma, they're probably the most challenging. Is convincing them to, it's really for your own good. I mean, if you don't take this every day, you will go blind. Okay, but again, the challenge there is it's not, if there's peer pressure, and then, if you remember peer pressure, that was a long time ago, but yeah, I remember I was forced to do stupid things because of peer pressure. Anyway, so if you look at the effects of the drugs, they either do one or both of the etiology, because again, the etiology was there's increased production of aqueous humor and or decrease in the drainage. So these medications will serve one or both of those causes. So they either reduce the production of aqueous humor or increase the drainage. Look at alpha-GAN, for instance. Look at the brimonidine. Has both effects. Okay, so not only reduces production but also increases drainage of the aqueous humor. Okay, let's go to surgeries. Again, the surgical procedure here is nice to know, although your pre and post-op care will make more sense if you understand the procedure. So I highly recommend you read the procedure. That way you know why your pre and post-op care is such. So laser trabeculoplasty, obviously it uses a laser. So this is one of the LASIK procedures you see on TV. So this is going to open the canals. Okay, so here, for instance, laser, they cut open here, so increases the drainage of the aqueous humor. And then we also have filtering surgery or trabeculectomy, which will again increase the opening. That way you'll have increased drainage of your aqueous humor. So here, this opening allows aqueous humor to freely exit the eye. So several procedures Again, the purpose is either to decrease aqueous humor production or increase drainage of the aqueous humor. So here's another one, laser. Oh, this is the same one we described here, laser trabeculoplasty. So the testable part is your, again, these are answers again to the patient. These are the rationales for your signs and symptoms. For nausea vomiting, just remember that anything that increases intraocular pressure is also increasing intracranial pressure. So when we go to acute neurologic problems next semester, you'll recall these again. These two are the very common symptoms of mild increased intracranial pressure. So the patient will have nausea, vomiting, and headache. Pretty much the same thing as when you guys have a hangover, right? When was the last time you were hungover, Miss Corbin?
Last week.
All right. What about you, Miss Wade? Tipping any Jack
I
Daniels
don't
lately?
drink. I don't drink. I don't
All right,
smoke.
very
Thank
good.
you.
That's good. Not like Vivian. Vivian, are you a Jack
Right.
Daniels
Not
girl?
like Vivian. Vivian. So no.
Anyway, so these are, you're hungover. That means you have increased intracranial pressure as well. So same symptoms, okay, nausea, vomiting, headache. Let's go to actions. Okay. Later, we'll also review how to administer eye drops. Although you've learned that in fundamentals, I will test it again. Okay, we know the head of the bed elevation that will maintain drainage as well as decreasing IOP and ICP as well. No bending, yes, we know that. So these are kind of redundant. We saw these already in cataracts, so it's pretty much the same. And here's the teachings. Again, the most important here is lifelong eye drop administration. And here is our... Okay, please read this, okay? I remember this is a select all that apply question. Oh, this is nothing new. We already did this. They just compiled the whole thing. Okay, eye drop installation. So wash your hands. Make sure you remember that the bottle must not touch anything, like the eyelash, for instance, or the eye sac. The bottle should stay sterile or clean. The position of the patient, tilt the head back with eyes opening up, and then where do you drop the eye drop? Where do you drop the eye drop? Okay, where is it? Is it on the eyeball? Into the conjunctival sac. Okay, not on the eyeball. Again, do not contaminate the tip of the bottle. And close the eyes gently. And then what do we do if we need a second drop of the same medication? Let's say the order is 2 drops on the left eye. Do you put the 2 drops one after the other?
No, you wait 3 to 5 minutes.
Okay, so it should be, you have to wait. The exception is, of course, the artificial tears. Those one you can drop one after the other because there's really no medication there. The problem with putting them one after the other is the first drop will just be washed out if you give the second one right after it, because the eye conjunctival sac can only hold so much liquid. So any drop you give will just run straight out. It will just drain, roll down the along the side of your eye. Okay, so the patient never got the second or maybe the first eye drop. Okay, so there has to be a time between eye drops. And you notice already, you're supposed to put pressure there, right? For 30 to 60 seconds to decrease absorption. Where do you apply the pressure? In the inner or outer canthus? This is referring to the inner canthus. That's the nasolacrimal duct. And that's it for glaucoma. Let's go straight to macular degeneration. So there's two types here. We have a dry and a wet type. Macular degeneration, just like the name connotes, is degeneration. You just got old. Or maybe you're not that old, because this can also occur in younger people, especially the wet type. The dry type is usually age-related. So we get old, we get the dry macular degeneration. But the wet type can occur in younger people. These are your risk factors. High blood pressure, high cholesterol, nothing new. So same thing as those that cause deterioration of your heart or your blood vessels, same thing. And we have other risk factors here. Okay, let's talk about the dry type first. The dry type is simply degeneration, wear and tear. Your macula is now breaking down. Okay, they're old. Okay. However, the dry type can turn into wet in certain people. We'll discuss the description of the wet type in the next paragraph. So with dry, one thing to note here is there's drusen bodies. I don't really know how to explain that, but they're yellow deposits found under the retina. Okay, that causes the macula to degenerate. Now, there is no cure for the dry type. However, you can preserve your vision for as long as possible. There are vitamins, of course, decreasing the risk factors, controlling your blood pressure, controlling your cholesterol, losing weight, eating better, all that good stuff. Stop smoking, right? So these are all you could do. There are eye vitamins made by Bausch and Lomb. They're usually vitamin A, vitamin E, beta carotene. So a combination of eye vitamins they put into one eye drop. So that's what you use. So there are really otherwise there's no cure for dry macular degeneration. Here's a comparison of both. In the wet type, the problem really here is in the overgrowth of new vessels. Here, so your eye grows abnormal blood vessels which are leaky. They're not normal blood vessels. Because they're leaky, they tend to leak fluid and also leak blood. And therefore, however, this is not the same as glaucoma in the sense that it doesn't involve the entire eyeball. These vessels are just found in the macula. Okay, this is on the behind your eyeball. So the vessels grow there, they become leaky, and they leak blood and fluid, like I said, and then that's what really damages the macula. So this is the wet type. This one, since it's caused by these vessels, there is a cure for this, meaning you can treat the patient with medications that will stop the growth of these vessels. And we have medications for that, usually the ones used for cancer, which we'll talk about shortly. These are your manifestations for each type. So this is, again, the macula. So the macula is the part of your eye that is involved for central vision. So therefore, if that deteriorates, then that's mostly your signs and symptoms. So you have problems looking straight ahead. So that is you still have good peripheral vision, but then your central vision is lost. So unlike glaucoma, wherein it was peripheral vision that is lost, mac degeneration is central vision loss. Here is the treatment. Okay, here's the arid formula. I mentioned their vitamins, so A, C, E, beta carotene, zinc, and copper also. And for the wet, here it is. You can read the photodynamic therapy right here, but here it is. The therapy uses a medication called verteporfin. So this is a light activated medication. And this is how they explain the procedure works. The question on the test really is related to the this drug. So the question will be, what is the effect, or more importantly, what will be the side effects if a patient receives this drug for this procedure? All right. So these are your teaching. That's very important. So avoid exposing or bright indoor light 5 days after treatment because medication is activated by light. And here is the vascular endothelial growth factor. This is also used for cancer. So obviously this is for the wet type. So this is now going to decrease the growth of those abnormal blood vessels. So again, that's it. Although this one will improve vision, however, once vision is lost, can you regain it though? Let's say the patient had either dry or wet type. So let's say they have the wet type, but they already had some vision loss. Will having any of these procedures, either the photodynamic therapy or the antivascular endothelial growth factor therapy, regain that vision that was lost? No.
No.
So as stated clearly here, you can only preserve what vision you have left, but anything lost you cannot regain. All right, is that clear?
Yes.
Okay. Or surgical management, they can also, besides giving this one, they can also do, they destroy those new blood vessels, those abnormal blood vessels that are leaking blood and fluid, so they can also destroy them. Post-op care will resemble glaucoma and cataract, because surgery is surgery. I guess they didn't even repeat it here. All right, so basically maintain safety because these patients are visually impaired. All right, let's go straight to retinal detachment. If I don't reach ear disorders, I'll just move the ear disorders to the final exam. All right, so I'll just test whatever we finish today, which should only be the eye, I guess. Or if we have time, we can do gout, and we'll probably include gout. Okay, retinal detachment, the first time this is mentioned was in the cataract surgery procedure as a complication. So therefore, the causes of retinal detachment is usually trauma. So you get hit with something, a ball, a baseball, a bowling ball, a football, whatever. So you got hit with something. That's the common cause of retinal detachment. And of course, eye surgery. Or someone, let's say, gouges your eye. So let's say Israel is trying to, mug Sheila. Okay, and then Sheila retaliated by pressing her thumbs into Israel's eyes. Okay, that could cause retinal detachment. So how do we know that Israel has it? So these are the symptoms. because the retina detached, so this is, the retina is supposed to be adhered to the eyeball. Okay, so that's how it works. So light enters here and then it's refracted up to the against the retina, and then the image is reflected there, and then it's interpreted by the optic nerves found here in the back, and then that goes to your brain and you know what you're seeing. So this is the detachment. So imagine a piece of paper that you line into a bowl, for instance. You line the bowl. So imagine a eyeball is the bowl. So this is the opening of the bowl. Then you put newspaper with glue and then pasted it against the wall of the bowl. Okay, and then if a portion of that newspaper peels off, then that's what we call a retinal detachment. So it's now detached from the retina. I mean from the eyeball. So this portion here, therefore, the space that where you detached it from, there can be bleeding there. So that portion may be, there may be a hematoma there, or whatever other matter can accumulate there as well. So therefore, if it tears, there will be bleeding. So that will account for the floaters you see in the visual field. So literally in front of your eye, you'll see floaters, which are particles or molecules of blood, red blood cells, that you see in front of your vision. Or a patient may also report light flashes or appearance of a curtain over the field of vision. So literally it's either the torn retina or the detached retina, or the blood cells that are floating in front of your vision. Here are the other causes. So any eye injury usually causes retinal detachment, including eye trauma during surgery. I'm not testing the forms of retinal detachment. We already described the signs and symptoms. Again, the most common report is the floaters in the field of vision, or the light flashes. It's surgically repaired, and just like cataract, after surgery, of course, you'll get ointments or eye drops, okay, particularly anti-inflammatory as well as antibiotic eye drops. So there are several methods in order to repair retinal detachment. We have laser photocoagulation. So if it's a small tear, laser can fix that. For larger tears, they'll use cryopexy. Cryo meaning cold. What they'll do is they'll use intense cold to freeze the area around the tear and causes an inflammation, and then of course reattaches the retina by a scar formation. For pneumatic retinopexy, this is using a dense gas. I could never remember what the name of the gas is. It's something called hexafluoride something. Anyway, it's a dense gas. It's not heavy, it's just dense. Therefore, dense is not the same as weight. Do you understand? Meaning something will be dense but not necessarily heavy. Does that make sense? Meaning you have more molecules in it compared to air. Air has what? Oxygen, nitrogen, and stuff, right? So the gas bubble used here is more dense. So any gas bubble rises, right? So the doctor injects the bubble of gas, and then depending on where the tear is, so let's go to the drawing. Okay, so let's say it's torn here. So the doctor will inject the gas here, and of course gas rises, and then the doctor will have to tell you though to keep your eye in a certain position, because if you move, let's say you lay down on your right side, so that means this is your eyeball, and the gas bubble again always goes up. So if the patient lies down on their right, let's say this is your right eye, and then he puts the gas bubble here, of course the gas bubble rises and will push this separated section back up against the eyeball, so therefore fixing it. However, if the patient moves, let's say lays down on the right side, that means the gas bubble will move over here by because of your position, right? Again, gas bubble always rises. So if you lay down on your right side, that means the gas bubble would move from pushing here to pushing now somewhere probably here. So it will not do its job. So that's the number one post-op reminder you should give your patients who receive this one. So the patient must maintain, it's here, it's written here. So the patient must avoid sleeping on their back during this time to prevent a sudden increase in eye pressure or even cataract formation. Plus the here, here, so that the bubble continues to press against the tear, right? Because otherwise it won't move. I mean, it won't work if you don't maintain the position prescribed. It's not always upright because it really depends where's the tear. If the tear is above, yeah, it will be upright. But what if the tear is somewhere on the side? So that means you're going to have probably to keep your head in a sideways position most of the time. Here's another procedure. This is the most violent. Scleral buckling. So a buckle is, a belt buckle, right? So they'll use a silicone buckle around the eyeball. How do they put that buckle in there? That's the part I don't want to see. If you're interested, again, watch the videos on YouTube. If you want, if you're brave enough, please, you can watch it. But literally, this is putting a belt, a buckle around the entire eyeball to reattach the retina. Again, how did they put that in there? Well, this is silicone. It's like a solid rubber band, well, wider than a rubber band, and they put it literally around the eyeball. Okay, so that means they'll have to insert it into the eyeball. That means they'll have to move your eye around in order to put the silicone in there and then wrap it and tie it up at the top. So that's scleral buckling. All right. Here's the gas bubble. And this is the scleral buckling. Okay. So imagine how they got that in there. All right. Questions again will be on the rationale for the symptoms, and then pre and post-op care. So any eye manipulation, if you notice, from cataracts to glaucoma surgery, there is always an attempt to minimize the eye movement, right? So covering the eye, for instance, wearing an eye patch, or let's say this one, activities to decrease intraocular pressure, or avoiding actions or activities that increase intraocular pressure. Yeah, we already know these, how to avoid increasing IOP, and also dark glasses, or at least eye patches. And I believe that's it. So we don't cover eye trauma anymore. So that was the end. We still have a little bit of time, but I won't be able to finish the ears, so we'll do gout. Gout is very, very short. It's literally a few pages. So 239. So the problem in gout is simply what? Oh, 359, sorry. Okay, there are two forms of gout. We have primary and secondary. Primary, you're just very unfortunate. It runs in your family. It comes in your family. Your body naturally produces high levels of uric acid. These are some of the risk factors: obesity, hypertension, or it could be also from your diet. It can also be a result of what we call crash diets, and it's been associated with aspirin as well as thiazide diuretics. These are your high uric acid foods. So alcohol would be any alcohol. Could be wine, could be beer, or any other hard liquor. Thiazide diuretics, as already mentioned, okay, increase uric acid levels. Okay, so this is for primary gout. Now, there's also a secondary gout, this time caused by drug therapy or from treatment, particularly cancer. One of the oncologic emergencies after chemotherapy is as the cells die, tumor cells die, when cancer cells die, either by radiation or chemotherapy, or however else you kill cells, so any cell when they die, whether they're normal or abnormal cells like cancer, always produce uric acid. It's a natural event when cells die, as well as potassium. Okay, so we have again primary and secondary forms of gout. Regardless of the form, signs and symptoms will be the same. So let's get to the symptoms. Uric acid builds up in the periphery, at the ends of your body. So it will affect your fingers also, but most likely your feet, your toes specifically. They attack usually the great toe. So they form uric acid, they form buildups here in the joint, and that is very painful. So the joint becomes very inflamed, very irritated, and yes, the pain is unbearable. People cannot walk with this type of pain. I know a close friend who gets this. It's not only seafood that is high in uric acid, it's also meat, right here. So not just seafood, this one says meat. Okay, this is not referring to seafood meat. Okay, this is meat, like meat, liver or pork, for instance. So if you have a high meat diet like all the time, that can also increase your uric acid levels. But mostly seafood is especially shellfish, right? Shrimp. What else are shellfish? Crabs. What else? Lobster, right? Okay, so this is what we call podagra. So this is the great toe. Okay, so that's your first metatarsophalangeal joint, so MTP. That toe, once it's inflamed, we call that podagra. It's so painful that you cannot wear anything on it, even just a sheet. You put a sheet, a thin sheet. Let's say you go to sleep, right, and you put a sheet over the toe. it already is very painful. So usually you sleep with your toes exposed. You cannot wear shoes, definitely socks, or even slippers. Okay, so any movement to the toe will cause extreme pain. So no matter how you walk, even if you walk on your heels, of course that will still cause movement of the great toe. So pretty much excruciating pain. Non-pharmacologic treatment, of course, you avoid all the triggers. So alcohol, no alcohol, and then all the foods that we talked about earlier. Weight management will also help because that is a risk factor for gout. Plus the weight also, if you lose weight, then that will be less pressure over the toe. Main focus of treatment is medication. So we have a lot of medications here. It will also depend on maintenance because if you have primary gout, of course you will be on maintenance medication. If you have secondary gout, then it usually resolves after the underlying condition is resolved. For instance, the one I gave you is an example. So after cancer treatment, then there's no more uric acid, so you're off the hook. But primary gout will require maintenance medication because they'll have to keep their uric acid levels low with medication and diet, of course, and avoiding those triggers. But they will have some exacerbations. We will end up cheating at some point, or something happens wherein we cannot comply with the therapy. So you'll have an acute episode, a really painful acute episode, and therefore the usual medications we use will, of course, no longer be effective. Okay, so let's start with the acute gout management and then we'll go to the maintenance. So during an acute episode, when there is severe inflammation and swelling and excruciating pain, we will give NSAIDs. This one is the preferred one, indomethacin, colchicine, which decreases buildup of uric acids in the joint. Colchicine, though, must not be used regularly. This is highly nephrotoxic, very harmful to the kidneys, so you have to drink lots of water while on this drug. But again, you should only be on it for probably 2 weeks. That's it. Any longer would be more damage than harm. Again, very harmful to the kidneys. Steroids will also be used. This is again all for the acute management. Okay, we're not starting with the maintenance yet. Okay, so we're still in the acute episode. So during the painful attacks, so patient will be on indomethacin, colchicine, and steroids. Any question about the acute management? All right, so the day-to-day management will just be allopurinol or Uloric, which is febu. I can't pronounce that. But anyway, most people are on allopurinol. I honestly have never heard of this. That's why I can't read it. Okay, here. This is a reminder. So during an acute attack, allopurinol will have to be stopped. All right. So this is the reason. For unknown reasons, a rapid change in uric acid levels may provoke or worsen a gout attack. So therefore, that means you have to stop taking the allopurinol because it will actually make things worse. So day to day, yes, you'll be on allopurinol, but once an attack is already occurring, meaning you have a swollen toe, very painful, stop the allopurinol and the doctor will put you on these. Any question? Any question?
No.
Okay, that's it. Here, I already mentioned this earlier. Aspirin should not be taken because it will cause retention of uric acid. And to answer the item on your blueprint about patient signs and symptoms, I got some of them here because these are coming from the horse's mouth. So this is how patients describe the pain in gout. Any questions, future nurses? So I'll move the ear questions on to the final.
Alrighty.
That's it.